It all starts under the sun. When sunlight hits your skin, it sparks one of the body's most crucial building blocks, vitamin D. UVB rays convert 7-dehydrocholesterol in the skin into cholecalciferol, also known as vitamin D3. First stop, the liver. Here, 25-hydroxylase adds a tag, creating 25-hydroxyvitamin D, or calcidiol, the main circulating form. Next, the kidneys activate it via 1-alpha-hydroxylase into 1,25-dehydroxyvitamin D, the ultimate powerhouse calcitriol. Calcitriol travels to the gut, maximizing the absorption of calcium and phosphate from food into the bloodstream. These minerals crystallize into hydroxyapatite, mineralizing cartilage to forge strong, resilient bones. But what happens when this vital mineral supply chain completely breaks down in a growing child? Welcome to rickets, a disease of impaired bone mineralization at the growth plates of growing children. At the growth plate, unmineralized osteoid accumulates, and chondrocytes fail to die off, causing the ends of long bones to widen and soften. Rickets is primarily divided into two main categories, calcipenic and phosphopenic. Nutritional vitamin D deficiency is the most common calcipenic type worldwide, caused by poor sunlight exposure and low intake. Vitamin D-dependent rickets type 1 occurs due to an inherited genetic defect in the kidney's 1-alpha-hydroxylase enzyme. In type 2 VDDR, the body makes calcitriol, but the vitamin D receptors are mutated and cannot respond to it. Phosphopenic rickets is often genetic, like X-linked hypophosphatemia, where excess FGF23 causes the kidneys to waste phosphate in urine. Chronic kidney disease and malabsorption disorders like celiac disease can also trigger secondary rickets. Because rickets affects growing bones, its physical signs appear prominently where rapid growth occurs. In infants, skull bones soften, a sign called craniotabes, followed by frontal bossing, giving the head a squared appearance. Along the chest, enlarged costochondral junctions create a beaded appearance known as the Rachitic Rosary. Diaphragmatic pulling creates a horizontal depression called Harrison's sulcus, alongside a protruding pigeon chest. Widened, flared metaphyses lead to visible widening at the wrists and ankles. When the child starts walking, weight-bearing causes the softened leg bones to bow outward or knock inward. Dental manifestations include delayed tooth eruption, enamel hypoplasia, and increased susceptibility to cavities. Generalized muscle weakness and hypotonia lead to a classic potbelly and significant motor delays. In severe acute hypocalcemia, infants can develop carpopedal spasms, stridor,
or even seizures. When vitamin D drops, intestinal calcium absorption plummets, causing serum calcium levels to take an initial dip. The body cannot tolerate low calcium. The parathyroid glands detect this drop instantly and pump out massive amounts of PHH, a state of secondary hyperparathyroidism.
PTH rushes to the kidneys to salvage calcium, but in doing so, it shuts down phosphate reabsorption, flushing phosphate out into the urine.
This is why serum calcium often stays deceptively normal, or only mildly low, while serum phosphate falls significantly, creating hypophosphatemia. Without enough calcium and phosphate to crystallize into hydroxyapatite, the bone scaffold remains soft, unmineralized osteoid. In an attempt to force mineralization, hyperactive osteoblasts produce massive quantities of alkaline phosphatase. ALP works to cleave mineralization inhibitors and free up local phosphate, spilling over into the bloodstream. In short, high PTH saves serum calcium at the cost of phosphate, while skyrocketing ALP reflects the osteoblast's desperate effort to heal the bone.
Diagnosing rickets requires a combination of biochemical blood tests and radiographic imaging. Serum 25-hydroxyvitamin D levels confirm nutritional deficiency when levels drop below 20 nanograms per milliliter.
Next is metaphyseal cupping. The normally flat metaphyseal border curves inward, showing widening and splaying due to axial mechanical loading on softened cartilage. Metaphyseal fraying appears as a ragged, brush-like margin, caused by disorganized, incomplete provisional calcification along osteoid seams. Flaring, or splaying, occurs as unmineralized osteoid bulges lateral and medial under the weight of the growing limb. Along the shaft, the cortex thins to an eggshell consistency, while the internal trabeculia become prominent, coarse, and osteopenic. Loser's zones, or pseudofractures, perpendicular to the cortex, representing stress infractions repaired by unmineralized osteoid. Softened diaphyseal shafts bend under gravity and muscle pull, producing distinct bowing deformities like genuvarum, valgum, or windswept deformities. On chest radiographs, expanded, cup-shaped costochondral junctions create the classic radiologic rachitic rosary pattern. The earliest radiographic sign of healing is the reappearance of the line of provisional calcification, a sharp, dense white band across the metaphysis. The cornerstone of treatment for nutritional rickets is simple: replace vitamin D and provide adequate dietary calcium. Treatment involves daily high-dose vitamin D3 for 8 to 12 weeks, or single-day STOS therapy, backed by elemental calcium. Genetic types require specific management: active calcitriol for VDDR1, and targeted monoclonal antibodies, like burosumab for XLH. Within weeks of treatment, a white line of provisional calcification appears on X-rays as bone remodeling kicks into gear. Prevention is key. All exclusively breastfed infants should receive 400 international units of vitamin D daily starting from birth. With early diagnosis and treatment, bone deformities correct, and children grow strong, healthy, and active.
Like and subscribe for more illustrated medical breakdowns.